As you've said in the title, is really talking about the use of contrast agent in the workup for the diagnosis of cholangiocarcinoma and gallbladder lesion. First of all, I will deal with cholangiocarcinoma. The incidence of cholangiocarcinoma is in the region of 3,000 per year. That's within the US, and about the same numbers in Western Europe. There is an increase in the incidence rate over the last few years, 30 years are shown in the US, with predominance of male patients compared to female patients. Now, just to put things in perspective, I mean, you see incidence of 3,000. The incidence of hepatocellular carcinoma in Western Europe as well as in the States is 15,000 per year. So it's about 5-fold less HCC compared to HCCs. Cholangiocarcinomas tend to be very slow-growing kind of malignancy, and they tend to infiltrate locally and metastasize quite late. 90% of these are extrahepatic. Now, ductal carcinoma can be classified as those between left and right side, and these account for 10% of the cases. The bifurcation is affected in 20%, and the proximal CBD is 30%, whilst the distal CBD accounts for 30% of the cases. Now, peripheral cholangiocarcinoma are locally aggressive tumors, and about over 60% actually present with satellite nodules, and these have perineural kind of invasions. Now, almost all these cases are adenocarcinomas, with the papillary type having the best prognosis. There's also the nodular and the sclerosing type of the adenocarcinomas. Now, most of these presents with ductal carcinoma presents with jaundice, with biliary obstruction. These patients present with weight loss, anorexia, pain, and sometimes fever. Now, the workup diagnostically is really, the first port call is really an ultrasound. An ultrasound will spot the biliary dilatation. However, to actually identify the extent of the tumor, whether there's any adjacent invasion, you really need to use ultrasound contrast to define the extent of tumors. And sometimes CT itself is actually rather difficult to actually locally define the extent of the disease. Now, the idea of using CT angiography is really to aid the surgeons in looking at resectability, which is really what you really want, because that will offer the best outcome. Now, this may be followed up by ERCP, PCT, percutaneous hepatic cholangiogram, or MRCP. Now, the tumor markers, CA or CA19-9, can be elevated in these cases. Next series of slides is just going to show you some examples. As you can see in this BMO video loop, you can see there is some dilatation of the biliary tree in both lobes of the liver, but you can't really identify any mass. Color Doppler is fairly useless, as you can see here. Doesn't really show any enhancement, as most of these tumors tend to be hypovascular. Now we'll look at the arterial phase of the scan here. As you can see, it's fairly very quickly, you can see the liver parenchyma enhancing through the arterial phase in the cell, but very little enhancement in this difficult classical tumor. And as you wait into the portal phase, the definition of the extent of the mass is clearly defined, as you can see here. And there is some intravascular circulation, as you can see, but this is relatively hypovascular tumor. The equivalent MRCP, again, this particular case is not going to define the extent of the tumor. You can see the dilatation of the left and right biliary tree, and the colon hepatic duct here is fairly decompressed. But the mass really lies in this area here. Another example, again showing bilateral bilobar biliary tree dilatation. When we look at the arterial phase in this case here, we can see the arterial circulation inside the main tumor. But again, as we wait into the portal or late phases, we can see the clear filling defect of this cholangiocarcinoma, this classical tumor, and with better border delineation. Now, in this particular phase, what we do is slightly higher MR. You can see dilatation of the biliary tree again, but you can see the clear definition of the margin. These masses can be quite lobular, and you can see also there is intraductal invasion of the tumor. What about this case? This is fairly extensive. The patient has been treated for a long period of time. The disease can progress quite rapidly. As you can see here, we can see the arterial anatomy, but the filling defect is all along the distribution of the vascular tree, or the bile duct, I should say. Now, the arterial phase, again, really hypovascular compared to the adjacent liver, and in the late phase, again, you see much better delineation of the extent of the tumor. This is fairly extensive disease, and there is metastasis in the periphery of the liver parenchyma. What about the peripheral disease? Most of these present as a suspicious mass on CT or ultrasound, or without contrast ultrasound, I should say. Now, by the time you see this lesion, you don't really know whether it's actually a cholangiocarcinoma unless you actually see biliary tree dilatation. But some of these masses actually present simply as a mass without bile duct dilatation. So these patients then tend to go for CT scan again to look to stage the disease, to look at the extent of the disease, to see whether there is any issue for resectability. And again, looking at the angiogram is really for the resection purpose for the surgeon. Now, you may want to end up, if you don't find a diagnosis, you may have to end up doing a biopsy to really know the characteristic of this tumor. And most, again, are really adenocarcinomas, as I said. Now, if they're not, you really need to screen for other primaries elsewhere. And colon, pancreas, and stomach are the other common primary sites that one need to look for. Some of the examples, one of the cases that I've done recently, you can see here the mass that enhances very homogeneously and washes very rapidly. And as you can see, it ends up very quickly with a rim enhancement. But also what one need to look at are the intravascular. The vessels inside, its integrity is still well maintained. Look like a metastasis in reality. This is another example here in the baseline. You see a mass, but once you put the contrast, look at the arterial phase, the lesion tend to be hypervascular. You can see the vessels there, but it washes very quickly. Okay, so this is the arterial phase. As we look on to the arterioportal venous phase already. Well, these lesions, as I say, can invade, and they can present with multiple metastases throughout the rest of the liver, just like looking like metastases. As you can see here in the late phase, there are multiple filling defects shown, which is fairly extensive, really, in both lobes of the liver. Now, what about gallbladder cancer? Now, the incidence is about 5,000 to 7,000 per year in the US, which is very similar to the same kind of incidence in Western Europe. It affects the sixth decade. Again, now in this particular case, you have a female to male predominance to 3-to-1 ratio. It is geographically, you have higher prevalence of disease. For example, in Israel, Mexico, Chile, Asia, in Japan, and particularly in the Native American women. Risk factors consist of gallstones, the classic porcelain gallbladder, polyps, chronic typhoid, and some other drug-induced types of risks. The first presentation is really, most of these cases actually discovered on pathology after routine cholecystectomy. And we may see, and there will be some classification histologically. And the key thing is really whether there's been invasion of the muscularis. Once this diagnosis is made, you end up having to do staging with CT of chest and abdomen. And you really want to do a quad-phase CT scan to really define the extent of the disease within the liver. Now, if it is negative for metastasis, you go on for a resection. Now, if resection is possible, this really offers you the best outcome with a 60% 5-year survival for gallbladder cancer in this current presentation. However, if you look at the second presentation, whereby patient present with jaundice, weight loss, rapid quadrant pain, by this time the lesion has been fairly extensive. You end up leading to biliary decompensation, and really the treatment option is really left with systemic chemotherapy. For example, with 5-FU or gemcitabine or capecitabine, which may also be effective in some of the cases. But in this particular group of presentation, the median survival with chemotherapy or radiotherapy is only about 9 months. One of the classic cases of cholangiocarcinoma mass, you can see here there's a mass. One thing you want to make sure that this is a mass and not a gallstone. So you do need to move the patient in different position to really make sure that this mass actually moves with gravity. If it doesn't, well, color Doppler is not going to help you, as you can see from this video. You may just see one of the vessels, but I think this is probably an artifact, but you don't really see any of the vascularity that easily on color Doppler ultrasound. With contrast, it's much easier. As you can see here in the orbital phase, the mass enhances quite vividly. And then you compare it with the adjacent liver parenchyma in the portal phase, you don't really see that as much rapid washout as you would expect for the malignant tumor, but if you wait long enough, you'll see some of the washout again already in the late phase inside, and there's still a lot of contrast uptake compared to the adjacent, inside the liver parenchyma. Once you've done the characterization of the mass within the gallbladder, you really want to make sure that there is no liver metastasis in the rest of the liver. So in this particular case, if you wait long enough, there's a small filling defect, and this patient is actually very poor, given that he's got liver metastasis. Some of the other pathologies, this is a much later phase, filling defect appears in fact this patient actually had multiple metastases spread all over both lobes of the liver. One thing you really want, some of the differential diagnosis, some of the things you've got to be careful and you can be mistaken. In this case, as you can see here, sludge, but with contrast, this sludge doesn't enhance at all, so it's fairly straightforward. The key thing is really, by moving the patient around, you shouldn't really be seeing this demographic. It's just a question of the indication when you do your baseline scan in the first place. Another case that can be confusing with cholangiocarcinoma sometimes is really with simple acute cholecystitis. But what you really want to make sure that there is no direct invasion of the swelling of the wall of the gallbladder into the adjacent liver parenchyma. As you can see here, with contrast, you get clear delineation of the swollen walls of the gallbladder and no invasion into the adjacent liver parenchyma. Small polyps enhances vividly as well, but the sheer size is a key thing here. But these, you need to monitor over time to make sure that they don't go beyond the 6 millimeter to ensure that they don't have any malignant transformation. Now, this algorithm that I'm showing you here is looking at the late phase uptake as well as the arterialization of these tumors. And by looking at the appearances, you can actually define whether these lesions are malignant or benign, or also looking at the actual tumor types. This is the algorithm that was published in the Epsom 2008 guidelines. And cholangiocarcinoma does appear in that particular algorithm. And you start with the late phase. If there is sustained enhancement, this is a benign lesion, but if it is no sustained, this is most likely to be malignant. And this is really where the cholangiocarcinoma category comes in. In the arterial phase, and I'll show you some of the examples, these lesions can be very variable in terms of their vascularization. They may either be hypo-enhanced or sometimes even see. It depends, again, on what you describe. And I think one has, the key thing here at the end of the day is really seeing the ductal dilatation. And then you would end up with the cholangiocarcinoma. Thank you.